This episode of Beauty and the Surgeon podcast is brought to you by Let's Get Checked. Let's Get Checked is an online company dedicated to making professional health testing easy and accessible. Let's Get Checked offers fast, affordable, completely confidential at-home health tests from a range of tests from STDs, male and female hormones, and even COVID-19. Listeners of our podcast who are new to Let's Get Checked get 20% off by using our URL, trylgc.com/beauty, and be sure to use the code BEAUTY20 at checkout. That's trylgc.com, trylgc.com/beauty, BEAUTY, and be sure to use the code BEAUTY20, BEAUTY20 at checkout. Do it. Getting tested is important. It's the responsible thing to do, and you know how important I think it is to make sure you understand your labs. Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner. I'm joined today, as always, by the loquacious,
very talkative
Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon. You're very loquacious.
Why do I have a pair of scissors in my sleeve?
Well, we'll get to that. So first, let me say that this episode, we're going to be talking about breast reduction. We have had a previous episode about breast reduction, and it's really good, so I highly recommend listening to it. We will reference it a few times, but before we get into that, if you are not watching us on YouTube and you'd like to see what's coming, I highly recommend it because I'm about to open a box that we received after our last episode. So you can find us on YouTube at Jason Martin MD.
We got hooked up.
We did. So if you listen to our podcast that is now 2 episodes ago, came out May 1st. Yep, May 1st, 2022.
Which is, don't you think that's always our favorite episode between you and I?
It's mine because I really want to know what you're into.
I want to know what you're into.
Yeah. Well, one of the things that Dr. Martin was into on our episode was LMNT, which is LMNT. It's a electrolyte supplement. And after that episode, they were kind enough to reach out to us and ask if we might like a box of stuff from them.
Yeah. And we said, of course.
Yeah. So
sure.
I have not opened this, and that's why Dr. Martin has the scissors, because I wanted to prove to everybody that...
I feel like I'm the one that's supposed to use the scissors and the knives and stuff.
You can. You want to cut the tape?
No, you go ahead.
So this box arrived a couple of weeks ago, like 2 weeks ago, and it has been so challenging not to open it. I actually put it in your office so that I would not touch it, but it's basically been Pandora's box. It's been calling my name.
There's 4 flavors, so...
There's more than 4 flavors.
Oh, there is?
There is, and they have a chocolate flavor, and in the winter they have chocolate mint, they have the spicy ones, which you've never had, the habanero, and there's so many flavors. So all they knew is that Dr. Martin's favorite flavor is the orange. And he doesn't like raspberry.
Yeah, I don't like raspberry.
And I love the raspberry. Yeah. So we
are
super
Amy
excited.
Decided, even though she's a teetotaler, which means you don't drink that much.
That is correct.
That the lime one is really good for margaritas.
The citrus. Oh my gosh, yes. I've not done that, but I seriously, I love a really salty margarita. So I think that it would be perfect. You put some tequila in that, it'd be so tasty. Okay. So, all right. So LMNT, as we talked about in our stuff we're into, is an electrolyte supplement. You mix it with water. They're very, very salty because it's high in sodium.
Yeah, because I was into hydration. Mm-hmm. That was one of the things I'm into.
But just hydration alone is not enough for someone who's very athletic like Dr. Martin. So you need some potassium, you need magnesium, important for nerve function, muscle firing, super, super important.
Yeah,
so, okay. All right. So just to prove it, I have not opened this box. Here goes the...
Amy is now opening the box for all the listeners. Looks like a shoebox.
It does look like a shoebox.
Whoa, yes. We got hooked up. Hello.
Those are for you.
Yeah, so we got, I got as much orange as I need for 3 months.
Right? And the raspberry. So, yes, so exciting.
So if you're looking on the YouTube channel, we just opened the box and now I'm going to set these up front.
This box is salty AF, and it is. Yes.
There we go.
Oh my gosh, the raspberry is so delicious. It is absolutely my favorite. And just so salty and raspberry. But very important mix of electrolytes. There's 1,000 milligrams of sodium, 200 milligrams of potassium, and 60 milligrams of magnesium. You guys know I love magnesium. It's an important part of muscle and nerve
We're
firing,
not sponsored by LMNT, but the fact they send us stuff, we highly recommend it.
So exciting. Yeah.
No, they're great. I love it. It's really changed the game for me from a hydration standpoint.
And sugar-free, they have, it says 10 calories, but that's just because there's some carbohydrates in the electrolytes, but they are sugar-free, super, super tasty.
Yeah. Thank you to the company.
Yeah. Thank you guys so much. Yeah, this is so exciting. I'm gonna keep one of my boxes.
All right.
Shout out to LMNT the whole time.
Yeah, they're the best.
Put you right there.
All right, let's do it.
So, yay. Right, put one of your orange. You're gonna represent with your orange.
Make sure that works.
Yep.
Okay. Good symmetry there, Nels. Okay, good.
Looks great.
All right.
Yeah. So thank you, LMNT. This is amazing. We're super excited.
All the people wanting to learn about breast reduction have to watch us opening boxes.
Well, great for recovery from surgery.
Yes.
So, yeah. So we've talked about breast reduction in the past, but it's been a while because what is time?
Right.
It's been several years now. So we always start off these episodes talking about surgery, talking about the statistics. You hear me say that like a normal person?
Yeah.
The statistics.
You've been working on that?
I have. Yes, I
Have
have.
you been practicing?
In the mirror, statistics. So
I know I can say it. I know I can do it.
Can do it. Just don't ask me to say ASPS statistics. 2020 is the
2020.
year that we're looking at. So there were a lot of things that happened in between the year, 19 and 20 that may have affected the numbers of breast reduction.
I'm not sure what could have happened between 2020
And 20. Yeah.
Not really sure.
19 and 20.
Yeah, so it went down a little bit, but
Yep.
still a fairly common procedure. If you look at all the procedures we do in plastic surgery, breast reduction is definitely not on the low end. It's on the higher end, but it's not anywhere near something like a breast augmentation.
Yeah. Or even, other major surgeries. But one of the things I found really interesting was there were no numbers for cosmetic breast reduction in 2000. But they were tracking gynecomastia, and we'll talk about gynecomastia a little bit in this episode because it's a male breast reduction. So interestingly enough, the change from the year 2000 to the year 2020, even though 2020 was down 11% from the year before, is only down 9% overall. In the last 20 years, only went down 9%. And that includes a huge drop from 19 to 20. So I think that's actually, it shows that that's becoming a more common procedure. The numbers for breast reduction aesthetically are a little bit deceiving, but around somewhere between 45,000 and 35,000-ish per year, if we take the numbers and kind of mesh them together.
Yeah, and this is not one of those procedures like we presented before that is done by other subspecialties like ENT and et cetera, et cetera.
Hopefully there's no dermatologists out there doing it.
Yeah, there probably is.
Yeah.
Somewhere. But it is primarily done by plastic surgeons. We, part of our board certification and representation in our societies, we present our numbers. So this is fairly accurate. It's a very common procedure, and it's a common procedure for all types of people. Large breasts that hang, that cause problems, can be on any type of frame. You can be bigger, you can be smaller, you can be a little overweight, you can be underweight. It kind of spans all different body types. And once you have that problem, it's hard to get around. It affects every part of your life, which I'm sure we'll talk about.
We'll talk about. Yeah. Yep. One of the things that we talk about in our first episode on breast reduction, which I do highly recommend people listen to, is kind of the makeup of the breast, or the way the breast is made of ligaments and fat and milk ducts. We had some great cross-section of so if you're interested in the more anatomy side of the breast itself, I would highly recommend listening to that first episode because we aren't going to go into that as much. We don't want to just say the same thing we said last time. So I'm going to try and mix it up a little bit. So let's talk about the 4 different types of breast reduction that are the most common. So full anchor, we have some great pictures on these on our next slide. What we call a vertical, which is probably one of the more common types of breast reduction, or a lollipop incision. That's also the same that we do for a breast lift. Sarah and I had a discussion about whether this is periareola or periareolar.
I say periareolar.
And that is the more correct term. And that's what I told Sarah. I'm like, you could technically say either or either, but it is more correct to say periareolar.
So peri means around the areola.
Yep. And then gynecomastia, which is breast reduction for men.
Which we do a lot of in our office. So there's 4 types of incisions. Okay, so the anchor incision, and if you look on the internet, actually we're going here now. Okay,
if you look at the picture we have.
If you look on our YouTube channel.
Drawn by Dr. Martin.
Oh yeah, I did draw these.
Yes, you did.
These are mine. That's good. So the anchor incision is around your areola, straight down the midline of the breast and along your inframammary fold, where your breast meets your body.
In our first episode on breast reduction, you didn't think that people would know what an anchor was because you didn't think boats used them anymore. I made the see, Nils remembers. Yeah.
Did I say that?
Yes, you did. You said that no one would know what an anchor is because no one uses
Can we just edit out my comments?
So we talked about the fact that boats still need anchors. Boats still exist.
Yeah.
Yep.
So an anchor incision it adds basically that incision at the base of your breast. Okay. So people come in a lot and they're very concerned about scars. I mean, scarring is the biggest concern with breast reduction. And this is especially true for people that are younger, less than 30, really haven't been through life yet. And, they don't want to add scars to their bodies. Maybe they're not in committed relationships, et cetera, especially young women. And we're very sensitive to that. To be very honest with you, the difference between an anchor and a vertical is not that much. You just have the addition of that scar at the base of your breast.
Which is in the inframammary fold. So that's actually the one scar that is hidden.
It's actually hidden. So a lot of times in plastic surgery, people watching this either probably have large breasts or know someone who has large breasts, and they're watching it to inform themselves, which is really good. So don't be drawn into this like East Coast, West Coast debate about anchor versus vertical, right? In reality, when I see a patient, I decide what they need based on what their anatomy is. I don't just say everyone gets a vertical or everyone gets an anchor. So if you go to an office like that and that's what they're saying, I have a huge problem with that. So let's talk about this real quick. I'll make this quick, Amy. I can tell when Amy's getting a little bit anxious because her hand is creeping over to my side.
Well, that's where the arrow is.
Okay, gotcha.
It's just because
you're not going to press
there.
the arrow. Off the arrow. All right.
That's just my posture.
No, absolutely not. So if someone comes in and they have a lot of extra skin below the nipple and areola, and it's a real saggy breast with a lot of stuff on the outside, they're going to need that anchor incision. You can't do enough of a skin removal with a vertical, no matter what someone tells you, no matter what the office tells you that you go into.
Well, I think your picture shows that really well. The picture in the lower left-hand corner with the blue kind of nipple and areola and the arrow, it shows in that green part right there. If you have a lot of breast tissue that is wide at the base, you got to think about it. The breast is a three-dimensional structure. So you can't just pull flat on it and think it's going to look normal.
Yeah, you can't chase the extra vertically.
Right.
You also have to chase it horizontally.
To make that shape. And that's why an anchor is perfect, because it rounds it out.
Right. And the majority of the people that come in for breast reduction surgery actually probably need an anchor. Now, here's the rub. Some people you can get away with the vertical, which we love. But the middle ground ones, the vertical, if they have a lot of extra skin, you still have to chase out that skin. And I was trying to think of this morning when I was in the shower, how could I explain chasing out the skin? But at some point, you're going to have to remove skin. And vertically, you can only remove so much. And so what's going to happen then is you're going to take that vertical incision and actually keep going past the breast, past the fold onto your belly. And I've seen that. People come in with vertical incisions that are evident underneath their, like below their bra.
Past where an underwire would go.
Which is terrible, right? You don't want to wear a bikini and have scars hanging out from your chest.
That's far worse than having an anchor incision.
Yeah. So then the second clever thing they do, which I've done, is you take that anchor and then you turn it. Again, you're going to have to watch the YouTube channel for this.
Like a J.
Like a J, and go along the fold. Well, if you're doing that, if you already are going to go right or left along the fold at the base of the breast, then you might as well just do an anchor at that situation. Don't get me wrong. I've done the J. I've done the extended.
Those are usually in cases, though, where there's like a distribution of breast that goes kind of really far lateral and the medial is okay.
Yeah.
Because I think the easiest way to think about this is you're taking a round surface, and if you were just pulling it straight together, you're going to make the bottom of the breast completely flat.
Yeah.
And that's not a natural looking breast. And, like right away after surgery, even with an anchor, like, yes, the breast will look somewhat like flattened out on the bottom, like on the bottom surface.
Yeah.
But if you don't have the anchor and you just, with everybody, we're just pulling it flat together like that, it's not going to look good on a lot of people. It's going to end up looking a little bit odd when it kind of settles in. Yep.
And so the incision should be the way to make your mind up about the incision. If you're the surgeon, I'm speaking to all the surgeons.
I was going to say,
now.
if you're the patient, you should ask your surgeon.
Yeah, I know, but whatever. You're the patients that will listen to us are the surgeons now. Is that you pick the best incision, best scar that will result in the best breast shape. Okay, that's really important. Everyone comes in, they don't want any scars, right? It's inevitable with this surgery. So you really have to be smart about planning the surgery. The surgery itself, if you go to a reputable surgeon, it's going to go well, and we'll talk about all that stuff, but it's going to be fine, and they're going to do a great job for you. But really, I pick the incision type based on the way the patient presents,
not their breast,
not solely based on what they want. Now, that's unusual. A lot of times with surgeries, I'm willing to be flexible. They'll come in, they'll be like, I don't want this and that. Okay, we can do this. But like when it comes to a breast reduction, which is fairly definitive, I want to know that number one, I can reduce their breast, definitively to the volume they want. And secondly, that the breast shape afterwards is going to look good. I'm not going to over-reduce and have no breast shape. I'm not going to under-reduce and have the same problem that they present it with.
And that probably is the biggest complaint, actually, with breast reduction, is that they were not reduced enough.
Yeah. So, and the incision type allows you to either take out more or less. If you do an anchor incision, you can take out more breast tissue, period. So if you're looking at yourself and like, oh, what do I need? If you have a lot of breast tissue below your nipple and areola, a lot of breast tissue on the outside of your breast, almost going toward where your armpit is, a lot of that hanging volume there, a lot of tissue.
Or your nipples are pointing straight down.
Yeah, you're most likely going to need an anchor incision. That's probably unavoidable. Now, there's exceptions to that rule. If you look on our YouTube channel now, you can see the different incision types. We showed that. But most importantly, you see that when you do this, you not only reduce in a vertical direction like you do with the lollipop, bringing the two vertical edges together, but you reduce in a horizontal fashion along the fold. And think about that. So I'm lifting that fold up and reducing. I'm bringing together vertically in the midline. So I am not only reducing the size of the breast in a horizontal fashion, but also in a vertical fashion. And Amy said 3-dimensionally. Imagine a sphere 3-dimensionally reducing it. I'm starting to get really, my head's hurting. So I feel like if we had virtual reality right now, we could show you
that
this.
Actually would be kind of cool. It could be like a breast floating just right here in between us.
So the whole reason I'm going on this diatribe is to empower you. So when you go in for that consult and you're really wanting a breast reduction because you have all the things we're about to talk about, just remember that pick the surgical approach that's going to give you the result that you want, the amount of reduction you want, and the shape that you want afterwards. If you want just a really flat breast with no shape, I guess you could do that. I just would not.
Yeah, that's not most patients. Yeah. I think the important thing to think about with any of these four surgeries, even for men, for gynecomastia, there is going to be some incision around your areola. And that will always be somewhat visible. I mean, that actually heals extremely well. Very rare to have any issues with healing in good hands with a good surgeon on that incision. The one caveat might be the periareolar incision can tend to stretch because all the tension is right around there.
Yeah, if you go into an office and they say they're going to do a big reduction through a periareolar incision, it's straight up not true. So you can only do a small reduction through that. And that's usually more for lifts, but you can definitely reduce a little bit.
A little, but you're also risking having scarring that is maybe not as good as
it's
if you
not
just
going to look that great.
Had a lollipop.
Especially if you have droopiness. Yeah. Secondly, you can liposuction the breast for women. I'm talking about right now.
Well, it's one of our frequently asked questions.
Okay. All right. You can liposuction that, but that's for women is maybe not that great. For men, for gynecomastia, that's universal. I liposuction everyone. If you go to our YouTube channel, or actually even better, go on our Instagram feed, Jason Martin MD, you'll be able to see some of our Instagram stories that actually shows immediate afters for gynecomastia. It's pretty remarkable. And a big part of that change really is the liposuction.
Yeah, and that's because with the gynecomastia, the goal is to make the chest as flat as possible.
Right.
Whereas with a breast reduction, for a variety of reasons, you're hoping to maintain a beautiful breast shape and functionality and other things.
Amy always comes in with okay, stupid. Right. You're trying to get rid of the breast, basically a mastectomy for a man. So.
It almost is, yeah, and in some cases it is. But, I think people get, the reason we're talking about this so much is because it is a very common thing that people kind of get in their head about this anchor, it's, that part is hidden. Everything else, around the areola, the vertical, which is most likely necessary regardless, unless you're having some mild gynecomastia surgery, those are visible no matter what. So the anchor just allows for the surgeon to have much better control of the shape and the outcome and takes the tension off the vertical. I mean, there's a variety of reasons.
We're not really pro-anchor, but we're not anti-anchor. You know what I'm saying? We're trying to make you understand that you need what you need. Yeah. So don't get too bent out of shape if someone tells you you need an anchor.
Yeah,
that's where we're spending so much time on this.
Get all that lateral breast tissue out of there.
And I don't think that people really know what anchors are anymore.
I feel like
they don't have anchors shaped like that anyways.
Yes, they do. Yes, they do. Have you been to a naval port recently and seen big ships?
Yeah, Amy, I've been hanging out at naval ports
hanging out
ever since COVID happened.
Right? Hanging out down on the docks. Yeah. Anchors still exist.
You guys wouldn't mind if I went on that aircraft carrier real quick, would you?
They do look.
I'm a plastic surgeon, board certified.
They do look like an anchor still. I mean, these boats still have to be stopped in the ocean. It's not like magic.
Oh my God.
All right, so let's talk about who's a candidate for this surgery. So who is a candidate for breast reduction? I think the main components here is you have to be healthy enough for surgery.
Right. So what does healthy mean, Amy? This gets confusing to some people.
Yeah, and this is elective surgery. So for us, we have our thoughts about that. It might be different for a surgeon that you see, but you have to have normal stable weight, and that's actually stable weight is one of the things I put on this list. So your weight needs to be stable. You need to be through puberty or menopause. You don't want to do these in the midst of those things.
Yep.
Hormones need to be stable, especially for men considering this procedure. Not breastfeeding, not pregnant, not thinking about getting pregnant in the near future. Normal blood sugar, normal blood pressure, like all the things that make a person healthy enough for surgery.
You don't have, autoimmune disease where you're on steroids. I mean, that's a major problem for wound healing because this is a big incision, a big open area of healing.
Very vascular too.
Right, that you don't have other medical problems going on. Okay, now we'll get in very superficially talking about the insurance component of this. If you go back and listen to our previous episode, we go into it in depthly, but it is important for people listening right now that maybe have children, right? Teenagers, they're really struggling with large breasts, and that's a subset of the population. It can be very helpful. I usually like to wait till they're 16. Into development.
We won't do it until they're.
But there are some cases where you can do it when they're a little younger if they have true, like in rare cases where they have, what do they call? There's a name for it. There's a medical name, gigantomastia or something like
Macromastia?
that. No, it's even bigger. So where it's
more than macro, right. Megamastia.
I mean, it would be something like that. But whatever the case is, where they're so disrupted in their life and there's so much discomfort that you would consider doing that at a younger age than 16. But we like to wait till development is at least somewhat done, so you know what you're dealing with, so you can set someone on this life path with a breast size that would be preferable to them.
Breasts will continue to grow throughout puberty. Yeah. So doing this surgery and then a year later having the breast tissue just continue to grow doesn't really serve the patient in most cases either. Mm-hmm. That's the same thing with menopause. A lot of women will come back, have had a breast reduction maybe in their 20s or 30s, and then they go through menopause, like, oh my gosh, my breasts are back.
Yeah.
You need another reduction. So you wouldn't want to do it in the midst of it for that same reason. Yeah.
I feel like that you played that Eminem song, My Breasts Are Back.
Oh, like Shady's back.
Yeah.
Breasts are back again.
My breasts are back.
Macromastia. Tell a friend.
Yeah, and so
we just lost all our listeners.
Yeah, it doesn't matter. We got the core audience. Mm-hmm. My friend, my medical student Dave, is still out there probably.
Yes.
Yep.
Yeah.
So I do think after like when you're around pregnancy times, letting kind of all that process of breastfeeding end and giving yourself some time for all the ducts and stuff that kind of expand with pregnancy and breastfeeding. Let them go away so you know what your baseline is. It's important to try to get people to their baseline.
Well, the ligaments need to tighten back up.
And to see where you are. And that comes with weight too. You don't want to do a breast reduction when you're going through massive weight gain or massive weight loss. You want to, so if you've had weight loss surgery, but you still have large breasts, you want to get to your plateau, area of your weight where it's stable, where you can maintain it, let's say over a year or something that's maintainable. And because the idea of a breast reduction is to match the breast with your body. So you don't want to over-reduce someone who's already losing weight. So then whatever breast shape that you create will go away with the weight loss, and vice versa if they're gaining weight.
Well, or under-reduce someone who then ends up losing a lot more weight. Yeah.
Exactly.
Stable hormones, I think, is really key. And that's actually something we don't talk a lot about in our episode about gynecomastia, but definitely warrants being talked about with men or women. If you have sudden breast growth that is not related to pregnancy or normal hormone changes like puberty or menopause, you should absolutely have that checked out before you have surgery.
I had a patient like this a long time ago who was younger, and her breast size increased at like age 24, like 3 cup sizes within a year. And that
just could be late puberty at 24.
They did a full hormonal workup in her, and they found some abnormalities. So
yeah, and especially for men too. I mean, like if you all of a sudden have breast growth, like you should definitely have that checked out. Like you need to have your hormones checked before you have surgery. Because again, you don't want to just have the surgery if you didn't deal with the underlying issue. That breast tissue can regrow. Breast tissue can grow again.
Yeah. We have a really good episode on gynecomastia. I feel like we're giving shout outs to all these episodes, but it's really good. You can go back and watch that gynecomastia episode. It's one of our more popular ones. It really goes through gynecomastia in detail. Yeah. And the workup associated with it.
Yeah. So basically, man or woman, if you are healthy enough for surgery and you have large breasts, and all these other things have been met, you're probably a candidate for surgery.
Right.
Yeah. So let's take a quick break. Get a word from our sponsor. Let's get checked. Shout out to LMNT also.
LMNT.
And we'll be back.
See ya.
Dr. Martin, I'm super excited to talk about our sponsor for this podcast, Let's Get Checked. If you've been a listener of our podcast, you know that we have never had a sponsor before, and that's because we're an educational podcast. We're not looking to monetize, and we also would never recommend something that we didn't believe in and or use ourselves.
So basically you're saying we're very choosy.
We're very choosy
Yeah.
when we come to our testing, but
Yeah.
Let's Get Checked is really aligns with our values. We talk a lot about monitoring your blood values of certain things. We talked recently about vitamin D serum levels. We talk a lot about hormone levels, and it's hard for some people to get to a lab, or you're afraid of the blood draw, or just, you're concerned about confidentiality. Like, you have a lot of concerns and you just don't do it. Let's Get Checked makes it super easy because it's completely confidential. You do it from your home. So there's really no excuse not to do it.
Yeah, and we did it recently. Both Amy and I did it. She looked at her women's health, basically her hormone levels, and I looked at mine on the men's health side with testosterone. It was very simple. You go online. Their online interface is really easy to use and good. We got the testing kit very quickly. And the test itself, actually doing the stick, you do a stick on the end of your finger, is not hard to do. It only took about 3 to 4 minutes. You put it back in a sealed envelope that's confidential, goes back to them. You get your results in 2 to 5 days. It's really that simple. And the best part is it's about empowerment, about you taking control and trying to do things that are positive for your health and life. And this is one way to do it, literally from the comfort of your own home.
Yeah, so they offer a wide range of tests. So they do men's and women's hormone panels. They do a full panel of STD testing. They also are now offering a COVID-19 test at home. So there are a lot of other just basic blood levels that you can get tested as well. And one of the things that we always say is you can't track what you don't check. So you might not know what's normal for you in the future if you're not checking it now, especially as it relates to hormones. And men's health specifically, I feel like, is a little bit undertreated. I mean, sperm counts are dropping by a large percentage in men these days. Most men struggle at some point in their lifetime with low testosterone.
And those men do not know what the symptoms of low testosterone are. Depression, anxiety, sleep problems, osteopenia or loss of bone, loss of muscle, and something we treat all the time, gynecomastia or male breast growth. These are real problems that can be improved or treated with testosterone. And these men do not know their levels. It's so easy to get checked. And this is why we're so excited about the sponsor.
Yeah. And Let's Get Checked is a completely CLIA certified lab, the CLIA lab. So they're a well-established, completely safe lab to use. You do get contacted after, so you get your results. I got a text at 4:30 in the morning, which I loved, that my results were ready.
And we're both up at 4:30,
yep,
so that was good.
Super excited. And you have access to not only a nurse, but also a physician. So a physician does review your results, and it gives you a little breakdown of like where you're sitting on those levels. Dr. Martin's had even comparisons of like where 2 of the levels should be in relation to each other, which is a really important thing to note.
Right.
Just being within the normal range is not always enough. So it really gave more information than that. You'd still want to, of course, reach out to your own doctor if you needed some additional assistance with these labs, or you did see something that was concerning. We didn't, thankfully, so that was good.
Yeah. We were both good. This podcast is about empowerment. It's educational. In my private practice, I'm a board certified plastic surgeon. We are all about empowerment, and this is one way to do it. So we're very excited about the sponsorship, and we're looking forward to using it for our patients moving forward.
Yeah. So as a listener of our podcast, if you're also a new time user to Let's Get Checked, which a lot of you probably are, we do have a 20% discount code. So you do need to go to our specific URL, and it is linked in the description box below, but it's going to be TryLGC, so TRYLGC, like Let's Get Checked.com/beauty, BEAUTY. And you'll need to use the code BEAUTY20 at checkout. Beauty again is BEAUTY 220. And you can pick a test, like any test you'd like, put in our code and get your test shipped to you. Getting tested is the right thing to do. It's lets you know where you're at and what's responsible.
All right. Well, let's get tested.
Let's get tested. Let's get checked.
Let's get checked.
Yeah. We're back. Let's Get Checked does hormone testing. So if you need to get your hormones checked.
Get your prolactin level checked.
That's right. Yep. Testosterone. They do a full men's health hormone panel, women's hormone panel. So yeah. All right. So let's touch a little bit about the insurance. Now, we keep saying about our previous episode, but we go into detail about insurance. Like we have multiple slides. We have a picture of the Schnur Scale. Like we really talk a lot about it. So if you're considering doing this surgery through insurance, I do highly recommend listening to the first episode because we'll go over the basics here, but we're not going to go quite as deep as we did on that episode. So, Dr. Martin, we talk about the Schnur Scale all the time. What is the Schnur?
I don't know. It's a calculation that the insurance companies make us do. It's based on your body surface area. And obviously, Dr. Schnur was obviously a person that came up with some algorithm to help decide. I feel like it's very arbitrary. It's difficult for me to work through this mentally because obviously, as a cosmetic surgeon, I want to reduce people the way I want to reduce them, what my vision is. And I don't like arbitrary numbers from an insurance company telling me how much I have to reduce. The insurance companies have to avoid fraud and people doing surgeries that aren't necessary for them. So you're going to have a Schnur calculation. There's going to have to be something that's quantifiable.
Yeah, or dangerous. I mean, the Schnur prevents people that have a BMI that's too high for surgery from being covered.
Right.
You know, that's, again, we've talked a lot about what makes a person a good candidate for surgery. You should be at a stable weight, and being morbidly obese and having a surgery that has an incision of this length is not a good idea.
Right. I forget there's an upper, we don't deal with it as much in Colorado, but there's an upper limit. It's recommended, maybe 32 for your BMI. In like a university setting, maybe 34, but that's, morbidly obese. So, and, in our office, we will not do a patient like that. We would refer them to the tertiary center, to the primary university center for that, because that is very problematic, and the increase in postoperative complications go way up. Infection, bleeding, pulmonary embolus, scarring, wound healing issues, asymmetry, deformity, loss of skin, loss of tissue. I mean, these go on forever. And obviously these are elective surgeries in the cosmetic sense, then you don't want to do that. This next thing that she has on here, when you got to have certain types of presentations. Amy, will you go through those real quick? Because you don't.
Yeah. So the insurance company, let's say your Schnur is great. Your normal body weight, your hormones are balanced, everything's good. Your insurance company is going to want to see other justification other than just like a doctor saying, here's this person's Schnur, I'm going to take out this much breast tissue. They want to see what your physical symptoms are. And that can be a variety of things. Bra grooving is probably a key one.
Yep.
Rashes from like skin on skin with your breast tissue, neck and back pain, difficulty exercising, all of these things are physical symptoms of having large breasts.
And so this gets down to the key on medically covered breast reductions. It's about your physical being. It's about your quality of life. It's about your functioning. So people that have large breasts have something called kyphosis. Amy, show kyphosis, because I'm not going to show it because I'm always kyphotic and I hate it. Exactly. This. If you look on the YouTube channel, this is the way I sit the whole time, and Amy's like, sit up straight.
Like, are you feeling like you're tall?
Make yourself tall.
Yeah.
And that's because that heaviness of the breast. When you're kyphotic, what that does is it leads to upper back problems, really thoracic and shoulder, where you get this kind of really distorted kind of alignment of your spine.
It puts pressure on the nerves that innervate the hand and the arm. And
then you'll see people have shoulder pain. They'll have shooting pains that go
numbness.
Down their arms. They'll have numbness. Then you start to get lower back pain. People listening to this probably like, oh yeah, he's telling me all the things I have.
Headaches.
Then you get both, not only headaches, but you get just literally pain on your chest. When that breasts get heavier and heavier, especially you live in a humid climate, you can get rashes underneath the breast. What do they call it? Interdigenous, like the rashes underneath where the breast sits on the skin. Then that can lead to fungal infections. I've seen that. That can lead to skin scarring. That's irreversible. These people struggle with exercise. They struggle with work. They have chronic pain. And I mean, can be very life altering. So people that qualify for insurance covered breast reduction, you know it when you see it. Yeah. It's like that when that judge said, what is pornography? You know when you see it. Like, this is the same thing with this. Like, they're really suffering, and you feel for these people. I feel for you if this is what you're going through. And so insurance companies, I think, are difficult, but if you fall into that category, most of the time, I think, Amy's going to kill me for saying this.
Don't say that.
Okay. You should get approved. Like, they should cover it because you have real physical reasons for approval.
Yeah, but just to state this, there are exceptions to this. Like, insurance companies can opt out of covering breast reduction.
And then you could sign up for insurance and not know you're opted out, and then you try to get approved and they say,
or through your company, they just don't cover it.
Yeah.
Like, that happens. So you could have all of these things. You could have all this documentation, and it may just not be a covered service code for your specific insurance company. It is not mandatory to be covered.
That's demoralizing.
It is. But so what do you do? So you've got all these physical symptoms, CAM, complementary and alternative medicine, with documentation.
This. You always talk about CAM. CAM.
Insurance companies require it. So most insurance companies are going to require at least 90 days.
So I come out of the room. Amy's like, "Do you have any CAM?"
Yeah, got a CAM. At least 90 days with documentation.
So what is a CAM?
Complementary and alternative medicine.
What is that?
Chiropractic, acupuncture, physical therapy, massage therapy. All of those things with documentation from the provider.
What about Pilates?
No. Okay. Not for breast reduction.
All right.
Yeah. That's not going to be covered. PT, like physical therapy. If your physical therapist is having you do Pilates moves, which when I many years ago worked for Health South, we actually did have a Pilates reformer that we'd use with rehab.
Oh, really?
Yeah, because it's great for rehab, but it's not called Pilates when you're having it done at a PT clinic. It's just get on the reformer and do these exercises.
That's interesting.
Yeah, and pictures. So insurance companies, you're going to send this into your insurance, they're going to want to know what your physical symptoms are, what your Schnur is.
They care.
They do care.
Yeah. You'll definitely get a Schnur calculation. That's 100% guaranteed, and you will definitely have photographs.
Yep.
If you don't want photographs, then you're not getting approved through your insurance company, because they will not approve you without photographs. And they want to see the grooving in the shoulders. They want to see that your breasts are very large and hanging. They want to see evidence of breast hypertrophy.
And these things are actually
macromastia.
Really good, because there are women who, BMI is we've talked many times about BMI and how much I dislike BMI. Let's say we have a patient who is normal weight, but has very large and very dense breast tissue. So her breast tissue is maybe making her be high on the scale of BMI.
Yep.
Well, then maybe it wouldn't be covered, right? Because they'd look at her and be like, oh, this person is overweight, right? Might have a BMI of like 29, let's say. But when you look at the pictures of this person, you see that
clearly they're not.
Right. The rest of their body is normal size, and their breasts are just that big and that dense.
Yep.
Breast tissue can be very heavy. So photographs might be the one thing that maybe tips the scales for you. And from our experience with insurance, limited as it is, most insurance companies won't even begin looking at a case until all of this is provided.
Yep.
Or they'll just deny it. And once it's denied, trying to get it approved after that is very challenging. So it's best to have these things first.
If it doesn't get denied, the doctor then has to call and
do a peer review.
Peer review with another physician who works for the insurance company.
Yep. And if you don't do that, then if that doesn't get approved, then you can file an exception. Like, there's many, many things. But having as much documentation, or as a lawyer that we've worked with before, as many drops in your bucket of proof, the better.
I like that.
Yep. That's one more little drop in the bucket.
Just another drop.
Cam.
Yeah.
Yeah.
Pretty much, if you go to a reputable office that does insurance-related breast reductions, they should know all this, and they're going to come in. They're going to calculate your Schnur. They're going to check through the check boxes and all the physical problems you've had. They're going to look at your cams that you've done. Sometimes insurance companies will even want an MRI, by the way, if you have spine issues.
Yep.
And
or mammogram.
They'll take the photographs and they'll send it off, and they'll get it approved or not approved, depending on what you have coverage for. So I think, it shouldn't be too complicated, but the problem ultimately is these insurance companies differ from company to company. And everyone could have Blue Cross if you got it through one company, not the other one. This one carved out insurance or breast reductions, and this one has breast reductions. It's just kind of potluck.
Yeah. And
nobody looks that up beforehand. No one's reading the small print.
No, but the thing is, you can always change insurances now and apply next year. Wait, so it's not all hope is lost just because you've been denied with one insurance company. So let's talk about some frequently asked questions regarding breast reduction. And these are things that we get asked all the time by people.
Right, that's good. I like this.
I think the very first one, how small can I be? Unfortunately, the answer to that sometimes for people who think they come in for a breast reduction consult, and really what they need is a lift with a small reduction, but that reduction would never be to the point that would be covered by insurance. It just isn't. In their mind, their breasts are huge.
Yeah, but they're post-pregnancy, a little bit bigger than when they started, and they're droopy. So the huge, they always say huge, but it's really a little bit bigger and droopy.
Yeah.
That's really the better way to describe it.
Yeah.
So I'm with you, sister, but that's just...
But it's just
reality. It's not going to be covered. That's a lift with a small reduction.
But for then, the patients who are definite candidates for a breast reduction, that is always the first question: how small can I be?
Yeah, and you could go pretty small if you care. If the surgeon cares about the way it looks and having some sort of nice breast silhouette and contour, you can only go so small. And I think it's important that you find a surgeon that does care about aesthetics. Cares about outcome. There are some people that do breast reductions, and they're more in the reconstructive world, and it's just taking certain X amount out, closing it, whatever, blah blah blah, you're on your way.
Well, or they're only concerned about making sure they get enough for insurance.
Yeah, for insurance. Yeah, and I feel strongly that if you're going to do this, even if it's covered under insurance, it'd be nice to go to someone who really is talking to you about the shape and how this fits with your body and proportionality. I mean, these things are hugely important for outcomes, aesthetic outcomes that are pleasing. But you can go pretty small. If you're a size F, you can get to a C.
For most people.
For most people. If you're a double D, you can get to a B. So I think the idea of someone going from an F to a A, which I've had someone ask that before, is just probably not going to happen without a mastectomy. It's just, you can't do it. But,
and a lot of that, is so based on the person. And we talk about this with all of the surgeries. We talk about breast surgery. Your breast size is unique to you. So like you may be, your breast might be really wide at the base. If you have a really wide based breast, we're limited by how much we can actually reduce that.
Yeah.
If you have a really narrow based breast, we can probably reduce it more.
Totally.
And make it look normal.
Yeah.
Make it look like a normal breast.
I think that's kind of like the take home point. Like you got to be treated as individual. The problem when you get insurance covered procedures, people get algorithmic. If you've ever hurt your knee and gone to an orthopedic surgeon, I don't even feel like the orthopedic surgeons know your name. It's like you go in there, they're like,
as long as they do the right knee.
Right knee.
Correct knee.
ACL, da-da-da. And I'm not even like giving them grief. I mean, it's just kind of repetitious. That's what they do all the time.
One more hip.
On the cosmetic side, and I'm prideful about this. I treat people as individuals. I want to know about you. I want to know what's your daily activities like? How active are you?
Well, or are you going to have kids still? Have you gone through menopause?
Right. So I think it's really important to have a surgeon that really is at least talking to you about expectations, about outcomes, about shape, about contour, about balance. Beauty is in balance. You don't want really small breasts and big hips. I mean, maybe you do, but the balance part of it, it has to kind of work with the rest of your body. And I think those kind of discussions really make happy patients. This one thing we didn't mention, but we mentioned in the last episode on this has the highest satisfaction rate of any surgery we do in plastic surgery, but also has the highest lawsuit rate. And the reason is exactly what I just talked about before. These patients go into an office like bam, 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 dum, 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 blah, blah. Here's paperwork, bong, boom, boom, you're here. And then before you know it, afterwards, they had scars they didn't think they were going to have. They don't like their scars. They don't like their shape. They wish they were smaller. They wish they were bigger. These are all things that could have been avoided with just communication.
Yeah, and mostly that's why I said the biggest issue is wishing you were smaller.
Yeah.
So that's why we're very clear with people, like how much can realistically be reduced. And that has a lot to do with some of these other questions that are coming up, what your life goals kind of are. Dr. Martin mentioned the liposuction component. People do ask that, like, can't you just suck the breast tissue out? Like people ask that all the time. Like, can't you just lipo it out?
You can, but it'd be like a empty sock hanging down, large breasts are two things, right, Amy? The breast tissue and fat.
Mm-hmm. Milk ducts.
Yeah, breast tissue and fat, and then the skin. So if you just remove the fat, you're leaving two things that would either increase size or cause issues, which is extra skin and extra breast tissue. So the fat alone, which never comprises 100% of breast, besides maybe a pseudogynecomastia patient, a male patient, is not going to give you enough of a reduction in most cases. And then secondly, it's not going to even solve the problem, especially if you have hanging breast.
Yeah, if your breasts are large enough to need to be reduced, even in a young patient, an 18, 19-year-old woman, has some ptosis just because of the weight of those breasts because they're that big. If you're not that big, well, then you're not that big. Yeah. This is not the episode for you.
Now, we'll definitely do liposuction with breast reductions, usually on the side of the breast going into the bra line, just to make sure that the contour as it goes around your chest looks really nice and you don't have stuff hanging over. Your breasts are all better, but then you have all this stuff hanging over your bra line. So we can address that too.
Which is a separate thing.
That's a separate thing. Yeah. That's not a breast reduction. It's not
included in the reduction. Yeah. So can you suck the fat out? Yes. But is that the solution to large breasts? No, it is not. And it's very indiscriminate. You'd be sucking out milk ducts, like all kinds of other things, which goes into our next question. Should I wait until after having children, or will I be able to breastfeed post-op? We have a lot of people come in for this procedure when they are, 18 to 25.
Right. And I have this discussion with them. And it's so weird to have a discussion with an 8-year-old about breastfeeding. And they're like, I really don't want to talk about this. Like, I'm not going to be breastfeeding. I'm going to college. I'm going to start my life. I'm not even thinking about kids right now. But it's an important conversation because you cannot be guaranteed that you can breastfeed after the surgery. There's two main ways to support the nipple and areola during the surgery. And we call it a pedicle. I've never found out a good way to say that, so I'm just going to say pedicle, look it up. Anyways, you can maintain that pedicle from above, and I use a superior medial pedicle.
And that's maintaining the blood supply to it.
Or you can do it from inferiorly, which is the old way to do it. Inferiorly really does go through all those ducts in most cases, so you're definitely not going to be able to breastfeed afterwards. Maybe in some cases the superior medial pedicle, depending on the size of the pedicle, would maintain the ducts enough and the nerve supply to be able to breastfeed afterwards. But that's a big if. That goes into the second caveat, Amy, which is the other question we get, which is sensation. People are like, well, I want to keep my sensation. I'm like, well, then don't do a breast reduction. Like it's not guaranteed that you're sensational, even if you do perfect surgery. So now most people with large hanging breasts don't really have a lot of sensation. The sensory nerves that go to the nipple are so stretched. They're not really functioning well. They just don't work well. And secondly, they're so unhappy, right? They're so uncomfortable that they would prefer just to have smaller breasts, even if they didn't have as good a sensation in their nipples and areolas.
Yeah, and that's up there with how small I can be questioned. If someone is coming to us and is very young and want to be as small as absolutely possible, but also is telling us that they have a goal of having children and wants to breastfeed in the future, like those two things may not jive. Like this is why you need to find out more about a person than just how small you can be.
Exactly.
Yeah. This is a good one. How long will my results last? Or will I need to have another breast reduction? Or another lift? And that's... Again, depends on where you started.
Depends on where you started.
Yep. Are you starting at 18? You started at 50?
Yeah. The breast changes over our lifetimes, right? It first starts out really fibrous with all that breast tissue, like a young woman's breast or even a young man's breast.
Right. Tendons are really tight. Yeah, ligaments holding it up. Cooper's ligaments. Holding that breast nice and tight.
Only the OG people listening to this podcast will know Cooper's ligaments because Amy struggled with that name. This woman can remember cell phone numbers off the top of her head, but she can't remember the name Cooper.
I had to finally think about Copper Mountain, and that's the Copper.
And there is a Ski Cooper in Colorado.
It's right by Copper Mountain.
That's a shout out to all the locals. Yep. But anyways. So, and then over time, the fibrous tissue gets replaced by fat. That's why the breasts get bigger with age, because unfortunately, every decade of life, especially after menopause, you gain weight. And when you gain weight, the fat gets bigger. It just gets more volume. And that it also preferentially affects your breast, which is now more fat than it is fibrous tissue. It's like a perfect storm. That's why you see, women as they get in their 50s and 60s, their breasts tend to grow. It's not because the breast tissue is growing. It's because they have more fat in the breast at that point. More fat, as we know, doesn't have a lot of support, does it, Amy?
Nope.
Fat's not going to hold stuff up. Fat's going to droopy, be jiggly, all the things that people hate. So I think that, it'll last a long time, but probably not indefinitely.
No, because your breasts are still going to age. It's the same answer to a lift.
Right.
Your breasts are still going to age. Gravity is still impacting your body. I wish, right, that you could have a surgery. It's not that your surgery results don't last. It's that you continue to age. Yeah. Like aging is still affecting you, unfortunately.
We should do like what they do on roofs. We just guarantee it, And you get this little piece of paper that says guarantee on it with like a blue ribbon.
12 months.
And then you read the fine print. We guarantee it for 2 weeks.
Yeah.
But I do think that, you may have to have another reduction. Fortunately or unfortunately, the practice tends to get these people that need reductions, and those can be very difficult. It's not the easiest thing to do. I tend to be pretty good at those surgeries because I'm creative and I can figure out different ways, but it's hard. They present with asymmetries. The scars are weird from the previous surgery. The nipples and areolas are different sizes and different locations. You got fat here and no fat there from the previous surgery. It makes it hard, but it's doable. And the patients universally are happy with that surgery.
Yeah. So whether or not you need another breast reduction is maybe not the issue, but like ultimately you'll probably need another breast lift.
With a little bit of reduction.
If you care. Yeah. Yep. This one, it was actually a question on our first episode about breast reduction. A woman who was like, she was like 55. Asked if it was too late, if her ship had sailed.
I remember this. Yeah.
If she was too old to have a breast reduction.
Should I just go out to pasture?
Yeah. Like, absolutely not. Like, are you too old to have a breast reduction? Healthy enough for surgery? And, yes, you can have a breast reduction.
What is it like in Asian culture when you get so old? And number one, I feel like they're all 100 years old. That they just go up into the mountains, like when they decided that they're like a problem for their family?
Oh, that's like the Native American thing.
Yeah, the Native Americans do the same thing too. This is kind of like this lady. Yeah. She's like, I'm not worth it anymore.
Like
I'm 55. 55.
Like, take me out back.
Yeah, I need to just go up into the mountains and not, just die.
No, but like for the most part, if you're healthy enough for surgery, you have large breasts, like Dr. Barnes said, your breasts as a woman will continue probably to grow throughout your life. You're probably not. If you're healthy enough, you're not too old.
And let me tell you something. Yeah, if you're healthy, even if you're in your 70s, even early 80s in some cases, but 70s, and you're active and you have large breasts that are getting in the way, I mean, a breast reduction could be life-changing.
Yeah.
This is not a super aggro surgery. It requires, in most cases, general anesthesia, but it's not strong general anesthesia. So it's not like it's putting you at very high risk for bleeding, for complications. Secondly, general anesthesia in a light fashion is very low risk for a healthy person. So I always say to people, you're more likely to get injured in a car wreck than have a problem with general anesthesia if you're healthy. Mm-hmm. So put that in your mind too. So if you're in your 70s and you're functional and you're active and your breasts are really holding you back, I mean, a breast reduction to me is kind of like a no-brainer.
Do it. Yeah. A lot of women wait until, after they've had kids and then life gets in the way and blah, blah, blah. And all of a sudden they're 50 and like, oh my gosh, like I've hated this for the last 30 years.
Or 55, where they should just go to the mountains and die.
Just do it. Don't do that. Yeah.
That just sounds very morbid, but
I know,
that was a joke.
Yeah.
Oh, one last thing, but go back to that real quick. Did you take the nipples off?
Oh yeah. Sorry. I forgot the very last question. Yeah. Did you take my nipple off?
Yeah. And that was the joke we made, that we have a little bed for the nipple.
Well, that was for the ear, but we could have one for the nipple.
I thought we did that for the nipple too.
Yeah. We have a little place where we put it. Because, there
I
is
get like
an
a little
incision all the way
Barbie
around
set
it.
up on the,
right.
Take the nipple off, just tuck it in for a couple hours while I do surgery. No, you don't.
It's not like a sticker. You don't just stick it back on.
Right. In very, very large breasts, there is cases where you just take the nipple off and reattach it as a skin graft. But in most cases, we don't take the nipple off and it stays attached. So we just move it up or down wherever it needs to be.
Yeah. It's kind of like, and it is just like a little biscuit cutter. We cut around it and then do the lift. If you go back to the slide with Dr. Martin's awesome pictures on it, you see that like nipple stays attached and we just move everything up and then we close everything around it.
So literally that's what you'll see is like soft tissue and then the nipple is still there and you move it like in a vertical up fashion.
Yeah. So it stays attached, just like your ear stays attached during surgery. All right. So let's talk a little bit about downtime recovery, right? This is the thing that everybody wants to know. Like what's it going to be like? Does it hurt? All this stuff. I always put this, and you think I'm making this up, that everyone asks me about swimming, but this is a common procedure done on people who are maybe in between like high school and college or college and grad school or blah, blah, blah. They do in the summer. When can I swim? So exercise, lifting, swimming. Most of your restrictions are going to lift at around 4 to 6 weeks. It's very rare that you'd have restrictions past that point, but the first 2 weeks are the most intensive. So for 2 weeks, we want you limiting the use of your arms. You do have an incision that needs to be protected, so you cannot swim. We don't want you to do anything that's super sweaty. You got to keep that incision out of the sun. So yes, there are restrictions, but by 6 weeks, you're pretty much back to normal everything. Yep. And only wearing one sports bra to do those things instead of 2 or 3.
Exactly.
Or none at all. Like, oh my gosh, when patients ask me if they have to wear a bra, and I'm like, not anymore. And they're like, at all? Like, not if you don't want to. The look on these women's faces.
I think bras inherently give soft tissue support, but you don't have to. No. It's not going to destroy the surgery.
Right. Like to sleep. Like, so many of our patients wear bras all the time. Like they're sleeping in a bra because it's so uncomfortable. Their breast tissue moving around at night.
Annoying as all get out.
Oh yeah. That's what I mean. Like
imagine.
It makes life totally different for people.
Know.
Time off work. Depends on what you do. Right. But it's not a very painful
Everyone's
surgery.
going to request 6 weeks. Right? You don't need that long.
No.
If you don't have a physical job, you could be back at work within 7 days.
Oh, even less. Yeah. I mean, working from home, doing some emails,
right.
Yeah, you can be back to work pretty quickly because number 3, pain. Pain is not very bad with this procedure.
It's crazy. It's not a painful surgery. Yep. And you think it would be. It's a very sensitive area. Mm-hmm. It's a large surface area that you're working on. Tummy tucks definitely hurt, but these breast reductions, for whatever reason, don't seem to hurt as bad. Now, there's exceptions to the rule. You may be that exception, but in your mind, you think that when you go in there, it's not super, super painful if it's done correctly.
Yeah, recovery is actually quite easy from a pain standpoint. It's rare that we have a patient who is taking prescription pain medication more than just a couple of days. Some people don't take it at all. They just do Tylenol right away because, it's sore. And yes, there's kind of that burning, stinging pain of incision, but
it's not that deep aching pain.
No.
That kind of muscle pain that really gets you off the seat or the bed.
Right, like muscle pain. I mean, having a breast augmentation, far more painful than a breast reduction because you're moving around the muscle. You've got more pain for sure.
Right.
So not super painful. Scarring.
I mean, this is always the X factor, right? Mm-hmm. When people come in, they look at you, they're sizing you up, how's his scars going to be? You can just tell. And I'm like, hey, they're pretty damn good. Mm-hmm. Actually, really good. And then I show them pictures wow, it looks good. I'm really happy about that. I mean, scarring is inevitable. You can't make an incision on someone's body and not have scarring unless it was a fetus. That's the only thing. That's the only human being. Well, God, I'm getting into the weeds here, but human organism who can re-heal without scarring. But when you're talking about us, you're going to have visible scars, but those scars are very well hidden. Mm-hmm. They tend to heal fairly well. And long term, I mean, rare is the time that we have major issues with our scars for breast reductions. Now, I have seen people with really bad scars, as a second opinion, and that's devastating. So it does happen, but it's not common. I understand why people get concerned about the scars, but I don't think it has to be. In reality, I don't think that it has to be the primary issue. But I understand why it is the primary issue for them.
Absolutely. But it's a great trade-off. And as Dr. Martin mentioned, I mean, as far as happiness goes after surgery, I mean, this is number one on the list of
Number
people
one.
who are just ecstatic.
I mean, they
after
come in, they're
surgery.
smiling, you know, and I'm like, look at this. I'm like, I don't care. This is the best thing I ever did.
Yeah.
I should have done it a long time ago. That's
Yeah.
what you hear all the time.
Yeah.
Like, thank you so much. You're the best. You're the best. You're the best. You're the best. I'm like, well, let's look at this scar and look at this. I don't care. You know, I'm so happy. Thank you. Thank you. Thank you. And it's invigorating. It's empowering for us as an office. So we love breast reductions. You know, ultimately the scar is a personal thing. It's an intimate thing. And it depends on how you feel about that. We get some people that could care less about scars.
I mean, most breast reduction patients don't care about
They
scars.
could care less.
Breast lift, people are very, very different, but breast reduction, like
Yeah.
it's solving the problem.
It solves the problem.
Yeah.
Especially if you have huge breasts and every time you walk in a room, all you do is think to yourself, I have huge breasts and everyone's staring at my huge breasts.
You don't wear clothes with buttons. You
Yeah.
literally wear a bra 24 hours a day.
Yeah,
Like,
or 2 bras.
Yeah, you can't find a swimsuit. Yeah.
What was the one patient that ran with 3 running bras?
Yeah.
3?
There are people who like ace
So 2 wasn't
bandage.
enough, so we're going to add a third one.
Yeah. Like, no, if 2's not doing it, 3 probably isn't going to make the difference. Yeah. So breast reduction is an awesome surgery.
Yeah.
Highly recommend listening to our first episode as well if this is where you found us, because it does have some more deep information on insurance specifically, but I think what we covered in this one was more involved on the recovery side and everything. So
I think this is probably
Yeah.
overall better.
you get to see your cool pictures.
There's not new techniques in breast reduction right now. There's some newer things that I do and people like me do, superior medial pedicles and some of these suturing techniques. And when you get into breast lifting, that's getting some newer stuff. I've done breast reductions and had breast implants. I've done it. Okay. I've done different types of gynecomastia surgery that involve breast lifts with liposuction. I've done all different types of breast reductions. I've done breast reductions on one side if you've had mastectomy and another, or breast cancer. So, you know, you could get into a lot of detail on these surgeries, but it's a very universal surgery that's offered in most places. So anyone listening to this, wherever you're living, there's a surgeon in town that probably does it well. And I think the take-home message is that, you know, if you go to someone reputable, the scars should turn out good. You should be happy with that result, and you're definitely going to be feeling better, and you're going to feel like you look better in your clothes for sure.
Quality of life way
Yeah.
better. Yes. All right. Well, thank you everyone so much for listening. If you are new to the podcast and you don't know
Hold
that
on
we
real quick.
have voicemail.
We got to move this so we can have all of our stuff. Okay.
Oh, yeah. So see all of our social media handles here at the bottom of the
Here you
screen,
go.
but
Right
also our
through
phone
here.
number is 303-630-9038. And I do listen to those voicemails. You can also text that number.
Are you getting any voicemail?
questions? Yes, I am. Our next couple episodes, we're actually going to answer some questions from viewers, and we're going to hear some voicemails from our loyal listeners. So do love it when you guys leave us.
Someone said that I had a strong Doctor Strange vibe.
Yeah, someone did say that. That's right.
That got all up in
Yeah.
my feels.
Give
You
it up
know,
for-
it's like, I don't know if that's a compliment or not.
Oh, it
because,
is.
Well, because his characters are always so acerbic and difficult.
Well, but you do give off the Doctor Strange vibes. Like, you've got that look.
All right.
Yeah. So I'd take that as a compliment. So we do appreciate everyone listening. If you like this podcast or find it helpful, we would appreciate if you leave us a comment or a like, a rating, review, or share us with your friends. It really does help. And we will see you next time.
Oh, last thing, jasonmartinmd.com. You can go in there and look at results and scars of
Pictures.
breasts. Yeah.
All right. Thanks, everyone.
See you later.
Don't forget to check out our sponsor, Let's Get Checked. Let's Get Checked offers fast, affordable, and completely confidential health testing for everything from STDs, male and female hormones, and even COVID-19, right from the comfort of your own home. And remember, new customers and listeners of our podcast get 20% off by using our URL, trylgc.com/beauty, and be sure to use the code BEAUTY20 at checkout. That's trylgc.com/beauty and use the code BEAUTY20, beauty, BEATUY 20 at checkout. Get checked. It's the right thing to do.